Welcome back. This is video number 17, drug-coated balloon, its role in bifurcation lesions. Is there a role for drug-coated balloon inflation in this bifurcation lesion? Would you prefer to do a pot or kissing balloon? And in this distal RCA lesion, what is the preferred strategy? Which is first, the drug-coated balloon in the side branch or the DS in the main branch? As said before, the main rationale for drug-coated balloon is to decrease the stent burden in cases as bifurcation lesions. And these are the items to be discussed in non-left main, non-instantary stenosis bifurcation lesions, including cases with different strategies, with discussion and technical points in form of questions and answers. With drug-coated balloon in bifurcation lesions, we can avoid discrepancies in size between the main vessel and the side branch, or between the proximal and distal segment of the main vessel. Also avoid plaque or cranial shifts, which is thought to be a significant cause of side branch narrowing after main branch treatment. In addition to less stent burden in the form of thickness, either overlapped or crushed stents, with favorable late outcomes. Drug-coated balloon supports the KISS principle. Keep it swift, simple, and safe. And these are the different strategies in using drug-coated balloon in bifurcation lesions. Drug-coated balloon only strategy may include dilatation of the side branch, main branch, sequential dilatation of side and main branches. Each may include main vessel dilatation. In case number 1, there is a distal RCA bifurcation lesion with osteotight PDA lesion Medina 001. With this significant discrepancy in size with the main vessel, a drug-coated balloon strategy was decided. Preparation was done with a 1-to-1 compliant and non-compliant 3.5 mm diameter with 2 mm protrusion into the main vessel, followed by a drug-coated balloon dilatation 3.5 40 mm 8 atmosphere for 70 seconds. And this is the final result. No pot nor kissing balloon inflations were done. In the second case, there is mid-distal long RCA lesion followed by RCA bifurcation lesion Medina 101. Drug-coated balloon strategy was chosen due to very high stent burden, including the mid-RCA and small diameter 2.75 mm of the PDA. After DS implantation of the mid-RCA, non-compliant balloon preparation was done with the 3 mm diameter for the distal RCA and 2.7 mm diameter for the distal RCA PDA lesion, followed by drug-coated balloon dilatation, one for the distal RCA 325 mm and another one for the PDA RCA 2.75 30 mm with an overlapping area. And this is the final result. Accepted non-flow limiting dissection in the distal RCA. No pot nor kissing balloon inflations were done. Proximal main vessel plus side branch drug-coated balloon dilatation is rarely stated in the literature. Considered enlarged side branch, which may be more important than the main branch itself. In this case, the proximal main branch is part of the long RCA lesion, so this strategy was decided to decrease the stent burden. Always check the main branch integrity after the procedure. EBC's current meeting and recent DCB consensus group suggests to preserve drug-coated balloon strategy in cases with Medina 001. Side branch drug-coated balloon strategy steps include side branch pre-dilatation, which may include another 1-to-1 proximal main vessel non-compliant balloon dilatation, followed by side branch drug-coated balloon dilatation, which may include 1-to-1 drug-coated balloon dilatation of the proximal main vessel. In the third case, there is mid-LED bifurcation lesion with a precious diagonal branch, Medina 110, in a patient with positive dobutamine echo. Non-compliant balloon dilatation was done with the distal 2.5 millimeter and proximal 2.75 millimeter, followed by drug-coated balloon dilatation 2.75 40 millimeter for 70 seconds. And this is the final result. No pot nor kissing balloon inflations were done. Main branch drug-coated balloon strategy, provisional strategy steps include proximal main vessel, main branch pre-dilatation, which may include another 1:1 proximal main vessel size balloon dilatation, followed by main vessel, main branch drug-coated balloon dilatation, which may also include 1:1 drug-coated balloon dilatation of the proximal main vessel. Studies investigating the use of drug-coated balloon strategy in the main vessel main branch are few. They include bifurcation lesions in which the side branch is not involved, usually done if there is another indication in favor for drug-coated balloon as small diameter sized arteries. In case number 4, precious single OM branch bifurcating into two equally small diameter branches with mediana 0.11. Sequential compliant and non-compliant 2.5 20 millimeter balloon dilatation of the branches was done with some protrusion into the main vessel with accepted result, followed by sequential drug-coated balloon inflations 2.5 20 millimeter 8 atmosphere 70 seconds, and another drug-coated balloon 2.5 30 millimeter for 70 seconds. And this is the final result. Sequential drug-coated balloon dilatation is indicated in cases involving the side branch in addition to the main vessel or main branch. This strategy is preferred in presence of technical or anatomical issue. In this case, the specific feature that favored full drug-coated balloon approach, not hybrid, is the precious small vessel diameter sized branches. In the fifth case, there is distal RCA bifurcation lesion with mediana 1.11. A sequential drug-coated balloon is decided due to the small size of the branches and long stent burden with a previous deployed stent in the mid-RCA. This is the final result after sequential balloon preparation and drug-coated balloon dilatation, accepted with an accepted non-flow limiting dissection in the distal RCA. No pot nor kissing balloon inflations were done. All dilatations and drug delivery was done with a long main vessel segment included. A 1:1 non-compliant dilatation of the proximal main vessel segment before drug delivery as a preparation would have been a good choice. This segment received a double dose drug, yet with a non-1:1 balloon diameter. Sequential drug-coated balloon strategy steps includes side branch and main branch pre-dilatation, which may include 1:1 proximal main vessel balloon dilatation, followed by sequential side branch and main branch drug-coated balloon dilatation, which may also include 1:1 drug-coated balloon dilatation of the proximal main vessel. Pending data shows drug-coated balloon have similar performance to DS in this strategy in an ongoing randomized study. Hybrid technique, DS in the main branch and drug-coated balloon in the side branch, includes dilatation of the side branch drug-coated balloon first, or DS in the main branch first, or simultaneous gelled drug-coated balloon technique. In this case, there is bifurcation LED lesion, mediana 1.01. It is a precious diagonal branch with two successive tight lesions, so a hybrid approach was decided. Side branch preparation was done, compliant followed by non-compliant 320 millimeter dilatation, followed by main vessel, main branch preparation up to non-compliant 320 millimeter in the main branch, followed by another larger size 3.5 15 millimeter non-compliant in the proximal main vessel, followed by side branch drug-coated balloon dilatation with two successive balloons, each 320 millimeter up to 70 seconds with an overlapping area. followed by main vessel, main branch DS implantation, 3.528 millimeter. Side branch rewiring was done through the struts to avoid guide wire jailing after a later pot, also in case of side branch compromisation and changing to two stent strategies. Followed by pot 3.5 15 millimeter 16 atmosphere. And this is the final result with an accepted non-flow limiting dissection in the distal segment of the side branch. No casing balloon inflation was done. In the seventh case, there is an LED diagonal bifurcation lesion, Medina 111. It is a precious single long, small diameter diagonal branch. After preparation of the side branch and the main branch, drug-coated balloon inflation was done to the side branch, yet with closure of the main branch, followed by direct stent inflation of the main vessel main branch. And pot, no kissing balloon inflation was done. Hybrid with side branch drug-coated balloon first technique steps include preparation as said before, side branch drug-coated balloon inflation, followed by main vessel main branch DS, followed by pot. Kissing balloon inflation is an option and will be discussed later. In this case, there is distal RCA lesion Medina 100 for provisional stenting. Since the stent will pass the bifurcation, it is considered a bifurcation lesion. After main vessel, main branch stenting, there is loss of the side branch. Pot and nitrates failed to open the side branch, so wiring through the struts and strut opening were done. Then balloon inflation was done up to non-compliant 1:1 diameter. With acceptable result, second pot would be a preferred choice here, followed by 1:1 drug-coated balloon inflation for 70 seconds. And finally, pot was done. This is the final result with some osteal compromisation, which is accepted. And this is after 4 months with total osteal positive remodeling. Hybrid technique in which there is main vessel DES first is either bail out or planned. After main branch, main vessel pre-dilatation, as said before, and DS implantation, pot is done. If there is significant plaque or carina shifts with malapposition, side branch rewiring through the struts is done, followed by pot and nitrates. After pot and nitrates, if the side branch is now not compromised with no plaque or carina shift, side branch drug-coated balloon is dilated, followed by a final pot. If the side branch is still compromised, strut opening is to be done, followed by either pot side branch pre-dilatation pot or kissing balloon inflation, followed by pot. After this pot, side branch drug-coated balloon inflation is dilated, followed by a final pot. In cases of hybrid planned technique in which the main vessel DS first is the preferred technique, side branch and main vessel pre-dilatation is done as said before, followed by main vessel main branch DS, followed by pot, side branch rewiring through the struts, strut opening, followed by another pot. This is followed by side branch drug-coated balloon dilatation and a final pot. Casing balloon inflations or pot side branch pre-dilatation are optional and discussed later. Simultaneous jailed drug-coated balloon technique should be highly considered in cases of bifurcation lesions in which there is very high possibility of plaque or carina shift. Two-stent technique is not preferred, and patency of the main vessel, main branch, is required from the start of the procedure all through to the end. Cases of this recent technique will be discussed in a later video. Regarding technical points, these are the frequent questions and their answers. Side branch dilatation, drug-coated balloon versus plain balloon dilatation. Two recent meta-analyses comparing both found that the drug-coated balloon were associated with significantly lower late lumen loss and reduced incidence of MACE. So, if drug-coated balloon is unavailable and the side branch dilated with a PUPA, highly consider a new angiography within a year with a possible dilatation with a drug-coated balloon. Another recent meta-analysis, including more than 1,250 patients, had the same conclusion. Extension of the side branch balloon. The balloon used for preparation and the drug-coated balloon should extend slightly about 2 mm into the proximal main vessel. This degree of protrusion is generally not expected to compromise the main vessel. This is to ensure adequate coverage of the side branch orifice, adequate balloon stabilization. A long extension will increase slipperiness with loss of drug and possible dissection. Also, adequate contact with the vessel wall. Drug-coated balloons are compliant balloons just for contact and drug delivery. Volume increase in the balloon will easily find its way in the unopposed proximal larger diameter main vessel, especially if long extension, at the expense of the side branch with less subtle contact and less drug delivery. Which step is preferred first? The side branch drug-coated balloon or the main vessel DES? In cases of main branch DES after side branch drug-coated balloon, if there is plaque or cranial shift, further ballooning may be required in the side branch, potentially leading to drug washout. This bailout step, side branch stenting, may occur in 10% of cases. And in cases of side branch drug-coated balloon inflation after the main vessel DES, may result in deformation of the main vessel stent, with the need for kissing balloon inflation to restore stent geometry. Also, stripping of the drug during recrossing through the stent struts. In addition, pre-dilating the side branch prior to applying drug-coated balloon may lead to dissection of the side branch, which increases the risk of implanting another stent. Implanting a side branch stent before the main vessel DS is easier than after implanting the DS stent. So, side branch preparation should be before main vessel DS. Summary of the studies. There is no direct comparison between both techniques. Most of the studies of the main vessel DS first strategy are bailout or comparison with non-compliant balloon dilatation. And studies of the side branch drug-coated balloon first strategy is not in comparison with any other strategy. So further data are required on the optimal order of the side branch drug-coated balloon during provisional main vessel DS implantation. Generally speaking, if the precious diseased side branch is likely to be compromised after main vessel DS due to anatomical factors as plaque burden or side branch angle, or not easy to access due to angulation, a side branch drug-coated balloon first strategy is preferred. What about drug-coated balloon kissing balloon inflations? This strategy should be avoided, not an alternative to sequential drug-coated balloon inflations. It may increase the risk of dissections in the proximal main vessel. Both balloons should reach the target diameter for optimum contact. Also, the oversized inflation proximally with two balloons may lead to less drug concentration per area delivery. In addition, proximal interaction between the two balloons takes an elliptical form proximally, does not enable proper concentric coverage of the vessel with suboptimal drug delivery to the vessel wall. After a drug-coated balloon only strategy for the side branch or the main branch, there is no rule for pot. There is no struts needed, needing dilatation at the ostium, and acceptable some degrees in the ostial area compensated later with positive remodeling of the drug. If needed for any procedure, postpone as much as possible to ensure drug delivery to the cells. Regarding kissing balloon inflations after bifurcation, If drug-coated balloon only strategy, there is no rule for kissing balloon inflations, since no carina shift. After hybrid strategy, the drug-coated balloon consensus guidelines state that are usually no need for kissing balloon inflations. It is avoided to reduce the risk of drug washout or disruption of the freshly delivered drug layer. It is advisable to minimize additional intervention whenever possible, yet these differences tend to diminish over time within minutes. So, if needed, delay as much as you can. In some studies, it was considered routinely after hybrid treatment of the side and the main branches, mostly followed by POT. It was not associated with adverse outcomes in the follow-up period. And in this study, side branch drug-coated balloon treatment was done after kissing balloon inflations, with no adverse effect on the main vessel stent healing and possible preservation of the side branch lumen. Steps taken if there is side branch compromisation. After hybrid PCI and POT, if there is significant plaque or carina shift or malapposition, side branch rewiring followed by strut opening and POT are done, followed by kissing balloon inflation or side branch pre-dilatation, followed by another last POT. If there is still compromisation of the side branch, another stent is added. POT after hybrid PCI. It is indicated as the last step routinely after the end of the procedure in cases of planned or bailout hybrid, after kissing balloon inflation or side branch dilatation, either single or re-POT as discussed before, in order to correct any malapposition because of stent strut attraction after side branch inflation, as a substitute to main vessel lesion preparation if not done before, and to ensure ostial strut opening since it is inflated with higher pressure than distal segment. Branch plaque shift, is it accepted after main vessel or side branch drug-coated balloon dilatation? Some plaque shift may occur in the other branch. Is it accepted? In this study, 9 months after the procedure, OCT showed increase in the mean lumen area of the side branch after main branch drug-coated balloon dilatation. It is positive remodeling of the side branch ostium due to diffusion of the drug to the ostium. So some plaque shift or pinching after main vessel dilatation is accepted. In summary, studies show several limitations related to discrepancy in study design, as small sample sizes and types of drug-coated balloons, and DS. Most available evidence supports the use of drug-coated balloon in the setting when side branch dilatation is planned, as in cases of isolated side branch disease or provisional stenting. It is also accepted in other strategies when there is another clinical or technical indication, all demonstrating promising results. Updated technical points as POT kissing balloon inflation, how and when, in various clinical and technical situations is crucial and essential. And this is the end of the video. Thank you for your attention and waiting for your feedback.